Shannon and Megan. We just want to give a brief disclaimer that there are some very graphic images in this presentation, so if you have a weak stomach, you may want to step out the room. So some trauma facts and figures we're going to start with. Trauma is the leading cause of death for people from ages 1 to 44. Trauma is the leading cause of death of children in the U.S. Trauma kills more people under age 44 than cancer, heart disease, AIDS, and other diseases. Approximately 150,000 people die each year in the U.S. as a result of trauma. A trauma occurs in this country every 4 seconds. Every 6 minutes, someone in the U.S. dies from trauma and another is permanently disabled. Each year, trauma accounts for 37 million emergency room visits and 2.6 million hospital admissions. 1 out of every 3 people will either directly or indirectly be killed by trauma. Advanced Trauma Life Support, ATLS. Advanced Trauma Life Support, ATLS, is a systematic and concise approach to the care of a trauma patient. ATLS was developed by the American College of Surgeons Committee and Trauma and was the first introduction in the U.S. and abroad in 1980. It provides medical and professionals with safe and reliable methods for immediate management of injured patients. ATLS is designed for medical professionals to follow a systematic approach in assessing a patient's condition, resuscitation, stabilization, and determine the patient's needs exceed the facility's capacity. So now we're going to discuss the various levels of trauma. So we have a level 1 trauma center. It's a tertiary care facility central to the trauma system. A level 1 trauma center is capable of providing total care for every aspect of the injury, from prevention through rehabilitation. 24-hour in-house coverage by general surgeons and prompt availability of specialties in the areas of orthopedic surgery, neurosurgery, anesthesiology, emergency medicine, radiology, internal medicine, plastic surgery, oral and maxillofacial, pediatric, and critical care. Some centers in this area that are level 1 trauma centers would be CHOP, Einstein Medical Center, and Temple University Hospital. Level 2 trauma centers, it's able to initiate definitive care for all injured patients. 24-hour immediate coverage by general surgeons, as well as coverage by the specialties of orthopedic surgery, neurosurgery, anesthesiology, emergency medicine, radiology, and critical care. Tertiary care needs such as cardiac surgery, hemodialysis, and microvascular surgery may be referred to a level 1 trauma center. Level 3 trauma centers, they provide prompt assessment, resuscitation, surgery, intensive care, and stabilization of injured patients and emergency operations. 24-hour immediate coverage by emergency medicine physicians and the prompt availability of general surgeons and anesthesiologists. Level 4 trauma center, it provides advanced trauma, life support, ATLS, prior to transfer of patients to a higher level of trauma center. A level 5 trauma center provides initial evaluation, stabilization, and diagnostic capabilities. And it prepares patients for transfer to a higher level of a trauma center. Now we're going to talk about care of a trauma patient. What are our teaching objectives? So number 1, timing and evaluation process of a trauma patient. Providing physiological support for the patient in the acute phase of the injury. Preventing and minimizing complications, providing emotional support and education to family and patients. We also want to prevent tissue hypoxia, achieving comfort and appropriate sedation of the patient, providing education to families regarding the disease process, and care and explanation of procedures. Now let's discuss the timing of death. Timing. The initial evaluation of a person who was critically injured from multiple trauma is a very challenging task. Every minute can make a huge difference between life and death. Mortality. It can be grouped into immediate, early, and late deaths. So an immediate death is caused by a fatal injury to the great vessels, the heart, the neurological system, and it can occur at the scene of injury, which is most likely what happened to this gentleman right here. Early deaths can occur within minutes to hours after an injury. These patients frequently arrive at the hospital right before death. Late deaths peaks from days to weeks after the injury. and is primarily due to sepsis and multiple organ failure. Trauma patient admission. We want to, number 1, rapidly identify the life-threatening injuries. We want to, number 2, initiate adequate supportive therapy for our patients. And number 3, you want to efficiently organize definitive therapy in accordance with the patient's clinical presentation. Or we want to transfer the patient to a facility that can handle this level of trauma. Primary survey. Isn't this what we've all learned about for the all semester long? Our ABCs. So airway, breathing, circulation, and hemorrhage, disability, exposure, and environment.
Multidisciplinary approach. However, I'm going to focus my assessment on airway management. First things first, when caring for a trauma client, it is important to stabilize their spine and use C-spine precautions in case they have suffered a spinal cord injury. A backboard should be carefully placed underneath of the patient, and a cervical collar should be applied. These precautions should remain in place until a spinal cord injury is ruled out by proper diagnostic testing. I'm going to show you how to properly apply a spinal cervical collar. So carefully, without moving the patient's neck, you want to slide the collar underneath of their head. Place their chin in the resting spot and tightly secure the strap. Next, we're going to show you how to log roll a patient to inspect their back and buttocks for injury. So when log rolling, you want to stabilize the head and keep the spine as straight as possible.
Okay, I have the head.
You want to inspect the back and the buttocks for injury or bleeding. When opening a patient's airway, the use of the jaw thrust maneuver should be utilized, continuing to immobilize the spine. So to do the jaw thrust maneuver, you want to place your 4 fingers underneath the patient's jawbone, pulling up, placing your 2 thumbs on the chin, and pushing out. This will open up the patient's airway while immobilizing the spine. When visualizing the patient's airway, carefully assess for blood, vomit, debris, or food occluding the airway. If the debris is found, immediately suction the patient to decrease the risk of aspiration and increase oxygenation. If the patient cannot breathe on their own due to extensive injuries, an artificial airway should be initiated.
Now I'm going to focus my assessment on breathing management. I'm going to go over how to do a focused respiratory assessment to a trauma patient. You're going to want to assess the respiratory rate by looking for the rise and fall in their chest. You can use a stopwatch to time it over 30 seconds and double it if it's a trauma patient. You're going to want to look at their accessory muscles. You can pull up the gown in order to see the ribs pulling inward and outward, as well as the sternal and the neck muscles. You can also check for crepitus, which is oxygen leaking in the subcutaneous tissues. In order to that, you just palpate around the neck and around the chest for a crackling, popping sound. You can also listen to their lung sounds. You can assess from the front if they are unable to move, or you can use a log roll if you have help and listen lung sounds on the back. You can look for signs of respiratory distress in your patient by looking at an increased heart rate or pulse, an increased blood pressure that will be compensating at first, but then will lower the longer the patient is in respiratory distress. Also, if they're using their intercostal muscles to breathe, if they're turning a blue color called cyanotic, or their pulse ox is decreased, usually lower than 92%. There are two oxygen delivery systems that are commonly used when a person is in respiratory distress in a trauma patient. They are the bag valve mask or the non-rebreather mask. The bag valve mask consists of a flexible air chamber and a face mask that is conducted by a one-way valve. When the bag is squeezed, it delivers air through the mask to the trachea and to the bronchus into the lungs. In order to use the bag valve mask, you want to cover the mouth and the nose of the patient. The mask should not go beyond the chin and should not touch the soft tissues of the eyes. You want to use the bridge of the nose in order to place the mask onto the patient. The seal is an important part of the bag valve mask. You want to use your non-dominant hand of your thumb and your index finger to make a C on the mask. You want to use your other 3 fingers to maintain the jaw and keep the airway open. You want to press the bag over 1 second. The partial rebreather mask there's usually 2 valves on the side of the oxygen mask. For the partial rebreather, only one valve has one of these plastic discs over. This is so that 1/3 of the air can go back into the bag, and then 2/3 of the air will be vented out through this mask. The O2 is delivered to the patient at 50 to 70%. The carbon monoxide stimulates the breath, and that's why this mechanism is used. It is an 100% non-rebreather mask. This has 2 valves that are both covered by a plastic disc. All carbon dioxide levels leave the mask when the patient exhales. Patient only receives the oxygen from the device. The oxygen delivers 80 to 100%. You want to make sure that you watch the bag to make sure it stays inflated, because if it does deflate, then the patient can suffocate because both of these valves are closed, so the patient is unable to breathe in oxygen if this bag isn't inflated. In order to put this device on, you want the patient to be upright and you want them to have a pulse ox on so you can continually monitor their oxygen levels. You want to attach the tubing to the oxygen device. You want to set the flow rate between 12 and 15 liters per minute. You want to hold the valve closed and watch the bag inflate. Don't put it on the patient until the bag is completely inflated. Once the bag is inflated, you want to hook it up to the patient around their head. You can use these green ties to pull the bag tighter so it's secured on the patient's face.
Now we're going to focus our assessment on circulation. The first priority is to ensure that there is no bleeding. If so, you want to control that bleeding. You want to assess for injury, which could potentially cause internal bleeding. Once that's all done and clear, you then want to begin your head to toe assessment of proper circulation. The first thing is I would want to put on a blood pressure cuff to take the patient's blood pressure to ensure proper circulation. Next, I want to assess for peripheral pulses to ensure that there is proper circulation to all extremities. Then I want to auscultate for heart sounds. For 1 full minute. I want to check the client's capillary refill to ensure that it's less than 3 seconds. Also want to assess the client's level of consciousness and ask some questions as to person, place, and time to ensure, to determine cerebral perfusion and impeding shock. Also want to note the presence of the skin color and temperature. You want to assess for any types of edema, and there can possibly be cyanosis, which can indicate oxygen deficiency. Once you've assessed circulation, it's important to manage circulation. By doing so, you will want to start 2 large IVs, either a 14 or 16 gauge, preferably 16. This will be useful to help analyze labs which will be drawn through the large bores to check for cross-type matching and to draw ABGs. In addition to the proper management of circulation, you want to administer proper appropriate crystalloids such as 0.9 normal saline or lactated Ringer's. It's important not to give the patient in this type of condition D5W because it will cause the fluid to leave the vascular space. It's also important to provide 3 milliliters of the crystalloid to replace every 1 milliliter of blood that's been lost from the client. Depending on the amount of blood loss, you may have to also administer blood products, which would be ideal to use 0 negative type because that's universal, and it can be used in all trauma clients in such settings. Assessing circulation in the care of a trauma client, it's also important to obtain an EKG, a 5-lead EKG, to assess the heart rhythm and rate and so forth. So now I'm just going to show you how to do so. You want to, a cool way that I learned is, just go over here. Placing the white on the right. Remembering that crane is always going to be on the ground. Smoke over fire. And chocolate over the heart. There you have it.
The next step in the primary survey is disability. In disability, we're going to be performing gross mental status and motor examinations. We're going to determine whether a serious head injury or spinal cord injury has existed. We're going to utilize the Glasgow-Coma scale. We're going to look at pupil size, symmetry, and reactiveness to light. We're going to observe spontaneous movement of the extremities and spontaneous respiratory effort as an early assessment of a spinal cord injury. We're going to assess the patient to see if they're alert. Do they respond to verbal stimuli? Do they respond to painful stimuli? Or are they unresponsive?
Now we're going to be talking about exposure, which is part of the primary survey. You want to remove the patient's clothes for a thorough physical examination. There's risks for hypothermia due to exposure of cold temperatures, infusion of room temperature IV fluids or cold blood products, and wet and saturated clothing. Hypothermism, which is a risk for spinal cord injury, you want to initiate treatment to prevent hypothermia. Treat prophylactically with administration of warmed IV fluids, blankets, heat lamps, and warm air circulating the blankets as needed.
To discuss primary survey monitoring and diagnostics. EKG and ventilator monitor leads, which monitors heart rate, identifies lethal arrhythmias, and oxygenation status. Then you have blood pressure and pulse oximetry, which is used for continuous monitoring to evaluate vital signs. Vital signs should be monitored every 15 minutes if the patient's condition is unstable, and every hour for a patient that is stable. Gastric intubation is used to decompress the stomach and decrease risk for aspiration of gastric contents if artificial airways are needed. A Foley catheter is used to measure the patient's response to fluid resuscitation and cardiac output. Foley catheters is contraindicated if urethral injury is evident.
So now we're going to talk about the secondary survey. This survey begins after completing the primary survey and the resuscitation phase. Allergies, medication, previous medical history, last meal time, and the events and environmental surrounding the injury is the ample survey that we'll do. We also want to do a head-to-toe assessment. We want to examine each region of the body for signs of injury, bony instability, and tenderness to palpitation. Evaluate the head and face for maxillofacial fractures, ocular injuries, and open or closed head injuries.
Now we're going to talk to you about some imaging and diagnostic tests that should be done in all trauma patients. So the CAT scan is the most definitive radiographic study in most patients. It takes images of the abdomen, pelvis, chest, spinal column, and the head. Then we have the MRI. The MRI assesses for neurological deficits and spinal cord injuries. Then we want to do a cross and match. This is one of the most important lab studies in the event that a patient needs blood products. ABGs should also be done. We want to assess the patient's oxygenation status and determine adjustments on mechanical ventilation. A urine drug screen and blood alcohol screening should also be done. These frequent assessments during trauma to address any issues that can be correctable and possibly decrease the patient's level of consciousness. Additional diagnostic tests that should be run are a CMP, CBC, PT, PTT, INR, and ammonia levels to determine the patient's overall health status.
Okay, so shock is the enemy. Shock is circulatory insufficiency that creates an imbalance between tissue oxygen supply and oxygen demand. That creates inadequate oxygen delivery to meet the cellular oxygen demands, causing end organ injury. Hypovolemic shock is the most common type of shock and occurs in trauma patients. Inadequate circulating volume that causes inadequate cardiac output to meet tissue oxygenation. The causes can be hemorrhage, severe dehydration, skin loss from burns, severe ascites, and severe edema. Time is a critical factor. Treatment priorities: secure airway and support breathing, control bleeding, and restore fluid volume.
So it's important to provide comfort measures such as verbal reassurance, therapeutic touch, educating and communicating with family members by explaining procedures, and pain relief and frequent pain assessments, which is needed to identify which drug provides best relief. I'm Dan.
I'm Shayna Hill.
I'm Megan Watkins.
And I'm Rhiannon White.
Thank you for watching our presentation.
Hope you enjoy.
Thank you.
Thank you.